Welcome back. This is immunological emergencies, also known as allergic reactions. These can be life-threatening. Depending upon what you're allergic to, you can go into a state called anaphylactic shock very quickly, and this can certainly be a life-threatening issue for some people. You do have something that actually can save their lives that you can give as an EMT, and of course that would be the EpiPen. So what is immunology? It's the study of the body's immune system. This protects the body from foreign substances and organisms. Excuse me. So basically, an antigen is something that you take into your body. It could be pollen, it could be a bee sting, it could be peanuts. So it can enter into your body breathing, eating, injection, and hopefully your immune system is well enough developed that it can fight off this antigen and you have no response whatsoever to it. But when that antigen becomes an allergic reaction, then that antigen now becomes what's called an allergen, and you're allergic to it and you can have an allergic reaction. And there's three different phases, so to speak, of an allergic reaction. The first one is just skin issues, the itching and the rash. The moderate is where you're throwing difficulty breathing in with it. And then the severe is where you not only have the skin, the difficulty breathing, but you also have blood pressure issues as well. So everyone needs to have some type of idea about what they're allergic to and try to stay away from whatever those allergens are to try to prevent them from having allergic reactions to begin with. So the allergic reaction, again, is caused by the immune system. The histamine and heparin in your body starts to get released. The biggest concern that you have with histamine is it makes your vessels very leaky, and so fluid starts to leak out of your vessels, and that's where the swelling starts to occur. For me, there was a movie called Pure Luck that there was a actor in there that got allergic reaction and swelled up significantly. If you've ever seen the movie Hitch with Will Smith, same thing happened to him. What is anaphylaxis? It's a life-threatening allergic reaction that causes shock and airway swelling. Typically, people that die from anaphylaxis, they die from them not being able to breathe. So here's some common allergens that can cause an allergic reaction. Insect stings. We live in Texas. We have fire ants, and fire ants can be a huge deal. I've got a real good friend that son got bit by several fire ants and spent 5 days in the hospital. Foods, peanuts by far are number one as far as allergic reactions. And, you know, if you're allergic to peanuts, there's peanuts and things that you may not realize. You may go to a restaurant and they fry their things in peanut oil and you're not familiar with that. You fry all your stuff with vegetable oil at home. So you need to make sure that you ask at restaurants if anything is fried, what is it fried in, especially if you're allergic to peanuts. Plants, things like poison ivy, poison sumac, poison oak, and then medications. There are certain medications that individuals are allergic to, and you need to make sure you know what those are and stay away from them. Now, with honeybees, they can't withdraw their stinger. They leave their stinger in you. Other insects such as wasps and yellow jackets, they stab you and then they can stab you again because the stinger is still there. But with honeybees, they're going to leave the stinger in you. If you need to remove that stinger, you're just going to take a credit card or your driver's license and scrape the stinger out. Make sure you scrape it opposite of the way it went in. So here's our good friend, the fire ant. If you've ever been bitten by a fire ant, then you certainly know what they feel like. They can be very painful. There can be little pustules come up as well. So you can get, you can build up an immunity to fire ants. It doesn't make it hurt any less, but you can take shots to help build up immunity to fire ants. Latex allergies. We used to have a lot of latex in EMS. All of our gloves used to be latex. We had some equipment that was made from latex as well. That's pretty much a thing of the past. There are latex allergies out there, and so because we use gloves that are made out of nitrile now, then it's really not a concern for us to put latex on any of our patients. But just beware that about 12% of the at least the healthcare population has got a latex allergy, and we have a more susceptibility to that because we're exposed to latex more than the general public is. All right, so make sure you do your scene size up. As far as scene safety goes, make sure that you have your proper PPE on. If you need to get additional resources or specialized resources there, then certainly call them and call them early. If you wait too late, then you're not doing anybody any favor. So if you call them early and then decide that you don't need them, you can certainly send them back. That certainly beats waiting till the last minute to call them and then not arrive in time. So this may not be an allergic reaction. I've had people call 911, and when we go out, they'll say, okay, I'm on this new medication, this hydrocodone, which is a narcotic, and every time I take it, I get lightheaded, so I'm having an allergic reaction. No, you're not having an allergic reaction. You're having a reaction to it, but it's not an allergic reaction. There could be trauma involved. So again, if there's any kind of bee stings in there, if there's any kind of chemicals or any other indications of a reaction, make sure that you note that. Make sure that whatever they're allergic to and having the allergic reaction to at this time, make sure you don't get into it as well. So do they look bad or do they look okay? You know, obviously if they look okay other than the skin issues, then that's a good thing. Now, these things can certainly progress. Just because you get there and all they have initially is a skin issue, that can certainly progress to a respiratory and a hypoperfusion problem. Look, listen, even smell, see if there's anything that you can gather from either smelling the environment or smelling something on the patient that may make you think of what the allergen was. Are they tripoding? If they are, then obviously they're having some difficulty breathing. If they're sniffing position, the same thing. What does their skin color look like? Is it blue? Is it red from a rash? Is it pale because of the hypoperfusion that's going on? So you can get a lot from just even across the room looking at a patient to see how severe of an allergic reaction they're having. The upper airway can swell very, very quickly with allergic reactions. Typically, the quicker the reaction occurs, the more severe reaction they're going to have. For example, if you and I go out and we eat shrimp, we both know that we're allergic to shrimp, but we really do like it, so we decide to go ahead and get an all-you-can-eat shrimp buffet. And you start to have signs and symptoms 10 minutes after we eat shrimp, and I start to have signs and symptoms 30 minutes after I eat shrimp, then you're going to have the more severe reaction. Usually the route of the allergen being introduced into the body also has a direct correlation with how quickly you're going to have a reaction. For example, if you're allergic to penicillin, and they give you a penicillin shot, you don't know you're allergic to penicillin, but you get a penicillin shot, you're probably going to have a reaction much quicker than if you swallowed something that you were allergic to. If you've never had penicillin and you're unsure if you're allergic to it or not, and they give you a penicillin shot, they're probably going to keep you there for at least 20 minutes to make sure that you're not having a reaction to that medication. It only takes a very short time for the airway to swell up, so make sure that you check that, and check that very frequently to make sure that it's not swelling. Position the patient in a tripod position, listen to their lungs. You certainly could have some wheezing going on with this allergic reaction. Probably a non-rebreather is going to be the order of the day as far as the amount of the type of oxygen you're going to give the patient. And if they are severe, then if they have their own EpiPen, then you can assist them, or you can call in with medical control and you can give the EpiPen to the patient. All right, so we see how swollen the tongue and the lips are here. Obviously, this lady's having difficulty breathing. So that's how significant that this can cause swelling to the upper airway. That tongue can get so large that it completely occludes the airway. They go into respiratory arrest and then subsequently into cardiac arrest. They may present with hypotension. If they're already hypotensive when you get there, then that's a pretty bad sign for you guys. You need to make sure that you check for a pulse. If they're unconscious when you get there, I certainly would check a carotid pulse before you would think about checking a radial pulse. But if they're conscious, then probably a radial pulse would give you an idea at least what their blood pressure is approximated at. If they have a radial pulse present, then their blood pressure typically is 80 millimeters of mercury or above. Check their skin condition. Again, there may be a rash, there may be hives, it may be pale because of the lack of perfusion. Also check their cap refill. Go ahead and do a Glasgow Coma Scale on them as well. Remember, this is divided up into 3 sections: the eye opening, the best verbal, and best motor. The best you can get is a 15, the worst you can get is a 3. These folks, we would love to have at least a 13 or above. Really, with anybody, we'd like to have at least a 13 or above. So make sure you check the Glasgow on them as well. And of course, this is part of the checking the disability. And then expose. Here you see these big bubbles here. Those are called hives, also called medical terminology, they're called urticaria. You also see the red rash here associated with this as well. Don't be afraid to remove clothing to see how far that this rash or this urticaria has actually spread. Obviously, the larger area that it has spread to, the more severe reaction that they're going to have to it. So with your initial treatment, you're most likely going to have them in a sitting up position because it makes it easier for them to breathe. Also put oxygen on them. Again, a non-rebreather is probably going to be the way to go. Because you're so limited in what you can do for these patients, especially if they are hypotensive, this is pretty much going to be a load and go situation because there's not a whole lot you can do. The epinephrine that you may give them with the EpiPen, the big treatment or the big effect you're getting from the epinephrine is it bronchodilates. So they're already having issues with their airway swelling, and so this epinephrine is going to help bronchodilate to where hopefully they're not going to suffocate themselves and go into respiratory arrest. Get your baseline vital signs on the patient. Get your sample history. Find out if it is allergic reaction. See if they know what they were allergic to and if they have ever been exposed to this before. So if you go out on someone who has been bitten by fire ants, ask them, have you ever had an allergic reaction to this before? Yes, I have. Did you do anything about it? Yes, I went to the doctor and they're sending me to a allergy specialist. Haven't been there yet, but so you already know that they have a reaction to the fire ants. It's a good idea to compare the last time that they were that they had an allergic reaction to a substance to whatever is going on at this point. See if it's better, if it's worse, or if it's about the same. Okay, so here again we have lips very swollen. I would almost bet that the tongue is probably swelling as well on this gentleman. Look at the skin. Again, you're seeing these little blebs right here. This is called urticaria. When you see the red, now sometimes they'll get just a red rash. They don't necessarily get the little blebs along with it, but There may be some swelling in the hands and feet. Obviously, we've seen it in the face, around the mouth, and the tongue. Where the rash is, there may be the skin may feel more warm there than it does in other places where there is no rash. Itching, and again, that's called a welt or a wheal or a bleb or whatever you like to call it, some type of rising there on their chest. Again, they may get nothing more than a rash. They may not get these. Here's the word urticaria. Again, that's the medical term for a rash that's associated with an allergic reaction. Respiratory, they're probably going to have wheezing, and because the entire airway is swelling, you may not only hear wheezing in the lower airways, but you may hear wheezing in the upper airways as well. They may have some hoarseness because their oropharynx is starting to swell. Same thing with the stridor. I mean, obviously, you'd much rather hear breath sounds that are crappy like this than not hear any breath sounds at all. That would indicate that they are not moving any air whatsoever. They are going to have an increased heart rate. They're going to have an increased blood pressure because the sympathetic response is kicked in. So they're in that fight or flight mode at this time. And so both the blood pressure and the heart rate are going to increase. Now, if they get to the point that they go into anaphylactic shock, then their mental status is going to start to become decreased really for two reasons. One is they can't breathe, so they're not getting the oxygen into their body like they should. Number two is they're hypoperfusing, so they're getting the blood flow to the brain that they need. The skin could be flushed and dry, or it could be pale, cool, and clammy. Probably if they're into the shock state of this, then it's probably going to be the pale, cool, and clammy. There could be some nausea and vomiting associated with it. And even as they're entering into shock, the heart rate's still trying to compensate for the hypoperfusion, so it's going to increase to try to compensate for the volume loss. So where does that volume loss come from? Well, we talked earlier about histamine being released, and histamine is going to make your vessels very leaky. It's like little holes in your vessels that are big enough to let the plasma out of the blood. It's not big enough to let the red blood cells, the white blood cells, and the platelets through. But the plasma will leak out of the vessel, and it's just kind of hanging outside the vessel. That's where you get the swelling appearance, and that's where you become hypotensive. So you haven't lost any fluid outside of your body. It's just not in the vessel anymore where it can help maintain a blood pressure. Do you have any history of allergies? What was the patient exposed to? How was the patient exposed? What signs and symptoms does the patient have, and how quickly did they come about? Has there been any progression? So have they gotten worse since they were exposed to this allergen? And then have you done anything prior to us getting there? Again, if they've got an EpiPen themselves, they may have already given themselves an EpiPen. So there really is no need for you to assist them at that point. They probably only have one anyway, but find out what has been done prior to you getting there. Then on your past history, obviously you're going to get the ample history on these folks. Also, something they may have done prior to you getting there is they may have taken some Benadryl. Benadryl is something you can get over the counter. It is considered an antihistamine. So what it's going to do is it's going to block the histamine release, and it will stop further progression of this event, but it doesn't reverse what's already happened. All right. So it's basically, you're not going to get better, but hopefully you're going to take the Benadryl to keep from getting worse. All right, so here we just have a localized reaction. Guy got stung by a bee, whatever. Again, let's say that this is the credit card or driver's license that they're using. Let's say the bee came in from this direction and the stinger is pointing diagonally down like this. And you're going to take your credit card or your driver's license and you're going to scrape it back out the way that it went in. Don't scrape it against the grain, so to speak. Don't use tweezers or forceps because the poisonous sac that is attached to that stinger is still attached to the stinger. So you need to make sure that you, because if you take it out with tweezers or forceps, then you're going to release the venom into the stinger. Wash the area with soap and water. Make sure you remove any jewelry in the area because these can swell. Be alert for any kind of vomiting or signs of shock or difficulty breathing or any of that. If they need oxygen, then give them oxygen, and make sure you monitor the patient's vital signs. So epi is needed for a patient if they are having difficulty breathing, and typically when it becomes systemic, meaning it's no longer just a local reaction, it has now migrated throughout the body, then this is when epinephrine is going to be called into play. And hopefully they have EpiPens there at home. When you guys get back to work, again, a real advantage that you guys have in working with paramedics is they have injectable epinephrine, not in an EpiPen form, but they have injectable epinephrine on both the engines and the ambulances that they can give to the patient, even though they may not have their own auto injector. If they're showing signs and symptoms of hypoperfusion and they're complaining of respiratory distress, then you need to make sure that you ask them, do you have an EpiPen? And I need it right now if you do, because time is of the essence. All right, so this is what an EpiPen would look like. They do have what's called an EpiPen, and they have what's called an Epi Junior for kiddos. They should have the proper one prescribed to them. The adult EpiPens have 0.3 milligrams of epinephrine in them. The Epi Juniors have 0.15 milligrams of epinephrine, so they have half of what the adult dose does. She has exposed the leg, obviously with shorts on. There wasn't really much to expose that leg. But you notice this is going to be given about halfway between the hip and the knee on the lateral aspect of the thigh, like you see here. This is hopefully going to go intramuscular. And make sure that when there is a protective cap that you pull off right here. There is no needle exposed at this point once you pull this cap off. Once you put this against the patient's knee, then that needle is going to be exposed, and you need to make sure you hold it there for 10 seconds to make sure that all of the medication has been injected into the patient, and then you can remove it. So you're, for lack of a better term, you're stabbing them with this. You don't just gently put it against their skin. You basically just stab them with this EpiPen, and that's going to cause that needle to come out and inject the medication. Epinephrine, adrenaline, you have this in your body. This is made by your adrenal gland, and you have this floating around in your body already. But obviously, if you're having an allergic reaction to this point, you don't have enough that's going to combat this reaction. So they will need that EpiPen to be injected into them. If they're having signs of a severe allergic reaction, respiratory distress, or hypoperfusion, the physician has to have prescribed the epinephrine to the patient, and you have to call in and ask for permission to give this to the patient. Now, guys, if a patient has their own medication, they can give it to themselves. You don't have to call in to get permission for that. But if you are going to give that patient their medication, then you need to call in to medical control. All right, there really are no contraindications to giving epinephrine. Again, the folks out there are not quite as schooled as we hope you are. I was at the station one night and a car comes up on the ramp and they're honking the horn, and there was an adult female in the front seat that was having a pretty severe allergic reaction. And I asked her, had she done anything? And she said no. So I said, well, we'll get you in the back of the ambulance and we'll give you some epinephrine. And she said, well, I'm allergic to epinephrine. And I said, okay, do tell. I've never heard of that. Well, my heart rate increases when I get epinephrine. Guys, that's what epinephrine does. Epinephrine will increase your heart rate. All right, so that's not an allergic reaction. That's not, I mean, sure, that's a reaction, but again, we took her in the back of the ambulance. We gave her the epinephrine, and she felt much, much better after we gave her the epinephrine. So, as I said earlier, here's the adult dose. It's 0.3 milligrams. This is a 1 to 1,000 solution, which that doesn't concern you at this point. The Epi Junior, this is 0.15 milligrams. If you're using your own, if you have your own on the ambulance, which I don't know of any ambulances around here that carry the EpiPens, they carry the Epi that you draw up into a syringe. But regardless of if you're using your own or if you're using the patient's, make sure that you look at it, make sure that it's still within date, that it hasn't expired. You really can't see the liquid in these. It'd be great if you could, but it's all but impossible to see the liquid that's inside these EpiPens. If medical direction authorizes use, then again, you're going to remove the safety cap. Go ahead and expose the leg halfway between the waist and the knee. Push it in, hold it for 10 seconds, and then go ahead and remove it. When you remove it, that needle retracts back into the EpiPen, but still this needs to go into the sharps container. And make sure that you, on your report, that you put what you get or how much you gave, the drug that you gave, meaning epinephrine, how much you gave, the route that you gave it. So in this case, it would be intramuscular, the time that you gave it, and then did the patient have any reactions, good, bad, or indifferent, to the Epi administration. So the biggest action that epinephrine has is it's a bronchodilator, and it will help them breathe better. It does constrict the vessels, but it's probably not going to constrict the vessels enough to bring their blood pressure back up to a normal blood pressure. So let's go back to the histamine being released. The vessels become real leaky. The fluid leaks out of the vessel into the third space tissue, and it's hanging outside the vessels. So when you give them Epi, that's going to constrict those vessels, and it's going to make them less leaky. However, it doesn't suck the fluid that's in outside the vessels. It doesn't suck that fluid back into the vessel to where it can help with their blood pressure, okay? So yes, they will get an increased heart rate. They may get pale and dizzy from this. They may get a little chest pain because of the heart rate increasing like it is. They may get a headache. They're probably going to be pretty anxious because you give this to them. And they may get nauseous and vomit. So all of these pale in comparison to what the benefits of giving epinephrine to this patient are going to be. Transport, make sure that you reassess the patient en route to the hospital. Sometimes they get better, and then eventually they'll get worse, and that's called a rebound effect. So make sure you keep an eye on the patient all the way to the hospital, see if they are, you hope that they would certainly improve en route to the hospital, but you know, your baseline goal is you hope that they don't get any worse. Consult medical direction if you feel that they need another dose. Usually another dose is given about 5 minutes after the first dose. Treat for shock. About all you're going to do for that is just cover them up and give them oxygen. And if they do go into cardiac arrest, then certainly you do CPR and use your AED. The patient's condition may be stable initially, but again, it can deteriorate. It can deteriorate very, very quickly. So if you do need to give more epinephrine, then by all means call in and see, and hopefully the patient has another EpiPen, and take that to the hospital with you just in case you do need to give that en route to the hospital. Make sure you reassess the patient. Your documentation should include the signs and symptoms, the reason that you did what you did, and the patient's response to the treatment. Okay, so obviously about all we talked about in this chapter was allergic reactions. Big keys, guys, make sure you know the drug of choice to give to patients with allergic reactions, which that's going to be your epinephrine. Make sure that you know the doses of the epinephrine, both for the adult and the Epi Junior. Make sure that you know all the signs and symptoms of an allergic reaction. Make sure you know the routes of the way that allergens can enter into a patient. So that's the big key points from this chapter. Okay, now we're going to move on to toxicological emergencies. You will have quite a few of these in Dallas. Seems to me that there's a little bit of illicit drugs in Dallas, anywhere from K2 to heroin to cocaine to methamphetamine. So it's around, but also remember that not all toxicological issues or illicit drugs. You know, a kid could get under the sink and drink Drano. So we have a pretty big array of things that we need to deal with toxicology. So each and every day we come in contact with stuff that can actually be poisonous to us. So acute poisoning affects about 5 million people each year. Chronic poisoning is much more common, such as every time you light up a cigarette, you're getting nicotine poisoning. If you've been doing that for 50 years, then that's going to be chronic. Alcohol, if you drink one beer, that's probably not going to do a whole lot, but if you're drinking a case a day, then you could certainly get alcohol poisoning and so forth. Deaths by poisoning are usually fairly rare, but you know, just some of the ones that have been made the news recently. Prince died from an overdose of fentanyl. Michael Jackson died from an overdose of propofol, which is a drug that they give you for anesthesia when you're going in for surgery. Back in my day, you had the John Belushis that were big heroin users. So people can die from overdoses and from poisonings, but a lot of times they will get help before they actually die from this. And there's things that they can do more so at the hospital than what we can do in the field to treat whatever poison that they have introduced into their body. So toxicology is the study of toxic and poisonous substances. A poison that is any substance that has a chemical reaction that can change the body structures or impair the body function. So an overdose of a drug is considered toxic. So let's say that you take 2 aspirin. That's not toxic to your system, but you take a 100-count bottle of aspirin, then yes, that can be toxic to your body. So what your primary responsibility in a poisoning is you need to identify what the poison was. Again, very small amounts of certain poisons can cause irreparable damage, or it can cause death. Things like H2S, which is hydrogen sulfide. People will pull in their garages at home. They'll make their concoction of hydrogen sulfide. They'll put it in their car, and then they open the container, and they can die within one breath of inhaling the hydrogen sulfide. So some of these, it takes a lot of the medication to become toxic, or a lot of the substance to make someone toxic. On other substances, it can be a very, very small amount. Here's the routes of exposure. This top one is inhaling. This one is injection. This could be drugs. This is probably the more likely one that we're going to see is drugs. But if you're a believer that you can inject bleach to ward off the COVID virus, which please don't do that. But if you're one of those believers, then obviously that would be a poison as well. Here we have something that can be ingested or swallowed. Also, these can get on your skin. This can get on your skin. This can get on your skin. This can get on your skin. So we have inhaled, we have injectable, we have ingested, and then we have absorption. So all routes of these can be deadly. As we talked with allergic reactions, Probably the ones that are injected are going to be deadly a lot more quickly than the ones that would be ingested or the ones that are absorbed through the skin or inhaled. Okay, so here we have inhaled poisons. This guy's inhaled of choice is rubber cement. You guys, if you've been to the store lately and tried to buy rubber cement or even whiteout or markers, you're probably going to have to show them your ID that you're at least 18 years of age. I would suspect this guy's over 18 years of age, so that doesn't mean that people over the age of 18 can't inhale poisons. So what do we need to gather? What substance was involved? And guys, you need to get the exact name. When you call poison control, the first thing they're going to want to know off the bottle or the whatever they have been exposed to, they're going to want to know the first word after it says active ingredients. It's probably going to be about 20 letters long. There'll be one vowel in there, and there's no way you can pronounce it. So you're better off spelling it for them, and they will know at least what the active ingredient is in that substance. Okay. Now, if they're sniffing gasoline, it's gasoline. If they're sniffing octane booster, then again, that's octane booster. You're probably not going to get them a whole lot of information off the gas can or the bottle of octane booster. When did this occur? How long of a period did the exposure occur? You know, if someone locks himself up in the car and wants to do carbon monoxide, how long have they been in that vehicle? Has it been 30 minutes or has it been 5 hours? What interventions has anyone taken? And then what's the effects on the patient? You know, are they having difficulty breathing because of this? Are they unresponsive because of this? So what signs and symptoms are they presenting to you with? So this is a very common inhaled poison. Most of the time it's inadvertent. It's not people that are trying to commit suicide. The two biggest issues that we have are sources of carbon monoxide are vehicles and home heating devices. Some people will lock themselves up in the garage with their car running for the purpose of suicide, but again, a lot of this is inadvertent. My son works in South Dallas, and several years ago he had a lady that her heater in her home quit working, so she went outside and got her Weber kettle grill, brought it into the living room, filled it with charcoal, and lit the charcoal and used that as a heating source, and certainly it's going to emit carbon monoxide. CO is colorless, it's odorless, it's tasteless. So one of the big issues that you may have is you may have your heater at your house is malfunctioning and you don't really know it. You go to sleep that night, you can't smell the gas, you can't taste it, you can't see it. You go to sleep, well, carbon monoxide will make you sleep even that much deeper, and you have no idea that you're being carbon monoxide poisoned. So make sure if you're going into any type of environment that you feel may be a carbon monoxide rich environment, make sure that you check the carbon monoxide level before you go in, and make sure that you have your air packs on to make sure that you're not exposed to the same thing that they have been. This basically, carbon monoxide basically just surrounds your red blood cells, and it won't let oxygen enter into the red blood cells for the oxygen and carbon dioxide exchange. Headache is probably the first thing that someone's going to complain of if they've been exposed to carbon monoxide. They can be dizzy, they can be nauseous and vomit, some difficulty breathing, there may be some cyanosis. Now, if they get to the point that they have red skin, or even if their lips are red, they are very, very heavily saturated with carbon monoxide. So you need to make sure that you realize they have been very exposed. Smoke inhalation, you guys have picked a job to where not only are your patients going to be subjected to smoke inhalation, but you are as well. This may burn the eyes. It can burn the skin, excuse me, irritate the eyes. It's fortunate that most of our airway burns are above the glottic opening or in the upper airway. Very, very seldom do we have lower airway burns, which is a good thing. And they can go into respiratory arrest or they can go into cardiac arrest. They may have difficulty breathing, coughing. They may be coughing up some black sputum. Their breath probably smells smoky. There may be some carbon or some singed hairs in their nose or their mouth. They may be coughing up the black sputum. So look around the nose and the mouth to see if you suspect that they may have inhaled some smoke. Ingested poisons, this is probably the most common thing that kiddos get into, is they just don't realize that whatever they're getting into can harm them. So it's certainly innocent on their part, but as adults, it's typically on purpose that they're overdosing on ingested poisons. So what do we need to gather for this? Again, you need to get the exact name. If it's something that they ingested and it's a drain cleaner or something like that, then again, you need to look for that active ingredient, and that's what you need to report to poison control. If it's a drug medication, you need to get the name of the drug. You need to gather up the dose of that drug, and you have to do some detective work on how much has actually been ingested. So look at the bottle. The bottle was filled yesterday. There was 50 tablets in that bottle, and there's 25 left in the bottle. So, and there's none spilled on the floor. So you would assume that they have taken 25 tablets out of that bottle. Make sure you bring it to the hospital with you. How long ago did this occur? And so always err on the side of caution. So, well, is it 30 or is it 25? Always go with 30. How long of a period did the exposure occur? Again, try to estimate a window for them. Has there been anything done prior to you getting there? Has anybody stuck their fingers down their throat, or did they give them some activated charcoal or anything like that? Try to get an estimation on what the patient's weight is, and then what kind of effects is happening to the patient that has ingested this poison. So they may have altered mental status. One of the huge problems with having altered mental status in a situation like this is they may tend to vomit after they pass out. They're no longer able to control their airway if they're unconscious. So you need to make sure that you maintain their airway and put them in a recovery position. So if they do vomit, they're not going to hopefully aspirate the vomit. Look for any kind of burns around the mouth or the nose. Cyanide poisoning, you can go to your local grocery store, go to the produce section and buy anything with pits like cherries, and you can ingest cherry pits and you can get cyanide poisoning from it. If you smell their breath and it smells like bitter almonds, then they probably have ingested cyanide. Now, this is something that you won't see on your ambulance anymore. This has been taken off the ambulance years ago. One of the big reasons it got taken off, in my opinion, is because you're so close to the hospital. One of the problems with giving this in the past is, like I said just now, that if they pass out after we give the charcoal and then they vomit, there's a huge airway issue. And so you won't see this on your ambulances when you get back out to the stations. But this is activated charcoal, and the goal of this is to absorb whatever that they have ingested. This that you see here you see the trade names for this. This will only absorb what's in the stomach. If they took it long enough ago that it's already down into the small intestine, then this won't absorb that. The hospitals actually have a type of activated charcoal with an ingredient in there called sorbitol, that it will actually make it down into the small intestine. So if the ingested poison has made it that far, then it should absorb it. Children will swallow horrible tasting substances, but they don't swallow a lot of it. I've gone out on kids and mom said that, they drank a gallon of bleach. I can promise you the kid did not drink a gallon of bleach. If that kid can't do the 1 gallon milk challenge in an hour, then I promise you he did not drink a gallon of bleach. So, but they're curious. They don't understand, what the consequences are to them ingesting whatever they've got in their hands. Also, think about alcohol for these kids. They see mom and dad sitting around at night drinking wine, and the kids ask mom and dad, "What are you drinking?" And they try to be cute and say, "Oh, it's grape juice." Or it's juice. They don't finish the wine that night. They recork it, and the 5-year-old goes in there and uncorks a bottle of wine while they're sleeping in the next day and drinks the rest of it because he wants some juice for breakfast. So kids can overdose on alcohol as well. All right, so you may have seen a lot in the news lately about a substance called Roundup. I'm sure all of you that have yards have used Roundup at some time in your life, and so it has been linked to non-Hodgkin's lymphoma, which is a pretty deadly cancer. So please be careful when you are putting your pesticides, your herbicides, things of that nature out, because these can be absorbed through the skin. So signs and symptoms of you being exposed to absorbed or surface contact poisons. First off, find out what they were exposed to. If it's a liquid or if it's a powder, guys, any powder, make sure you brush the powder off before you start flushing it. If you flush it while it's still in powder form, it's just going to turn into a slurry, and it's going to be all but impossible to get off the patient. So make sure you brush any dry powder off first, and then you can flush it with water. 20 minutes minimum on flushing skin if you need to flush their skin. There may be some burns, like you may be exposed to an acid, or you may be exposed to an alkaline. A lot of people think acids are worse than alkalines, and that's not the case. Whenever you are exposed to an acid and it gets on your skin, it has what's called a coagulation necrosis. And what that means is it starts to burn through your skin, it starts to coagulate and stops it from burning any deeper. Whereas your alkalines have what's called a liquefaction. So that means as it burns down in through your skin, it's liquefying everything, and it can make it through, make it down into your skin and your subcutaneous tissue area a lot more readily than the acids can. So water is going to be the universal antidote if you have anything on the skin. Again, a minimum of 20 minutes. Remember, if it's a powder, make sure that you flush the powder or brush the powder off before you flush it. Okay, this guy, I would guess, is probably doing heroin at this point. You see his arm here. You see this isn't his first time. Make sure that some people are not quite this obvious. This guy may have a Monday through Friday job that he has to go to work. He doesn't want people seeing the track marks and the necrosis when he goes to work. So he either A, wears clothing that covers this up, or he's going to be a little bit more discreet in where he injects the medication. So if you see somebody that looks like this, and it's not so obvious that there's a needle that says heroin on the side of it sticking out of his arm, you don't see all these needle track marks, then you need to start looking and see if there's other places he has been injecting. Sometimes they'll inject in between their fingers, in the webbing between their fingers. They'll do the webbing between their toes. They'll inject under the fingernails or toenails. They'll inject under the eyelids. So they'll inject in the vein behind their knees. So there's other places that they can inject other than in the arm, like you see with this patient. Make sure that you secure their airway. If they need oxygen, then certainly give them oxygen. Now, here again, this is probably a heroin overdose. He's probably breathing 4 to 5 times a minute. Obviously, oxygen is not going to make him breathe any faster, so we would have to get our back valve mask out and ventilate the guy and support his ventilations. Okay, so inhaled, 2 of your more common ones are going to be your carbon monoxide and your smoke inhalation. Ingested alcohol by far is going to be number one because of the shelter in place we've had recently. A lot more people are drinking a lot more alcohol. There may be illicit drugs that they have been taking, chemicals, food poisoning, plant poisoning. All right. Absorbed would be chemical exposures, and injected would be things like narcotics, insulin. Sometimes they can overdose on insulin. It's not necessarily poison them, but they can certainly overdose on it. Usually it's by accident. And then illegal substances other than narcotics, like again methamphetamines or whatever other kind of illegal substances that they decide to inject. All right, so do your scene size up, find out how many patients are involved. Sometimes heroin addicts like to do it in groups. So just because you find one doesn't mean that's the only one that's going to be there. Do you need additional resources? Do you need to take ceasefire precautions? And please, guys, especially with your illicit drug use, especially with your illicit drug use with needles, please, please, please make sure that you are on the lookout for needles that have probably been shared by everyone there, and make sure that you stay away from those needles and make sure you have your proper PPE in place. As far as the nature of illness or the mechanism of injury, the dispatcher may tell you en route ahead of time, and that's great, but don't get tunnel vision and think that every time the dispatcher tells you something that's exactly what you're going to find at the call, because that's not always going to be the case. If not, if the call just comes in as a sick person, look for clues, and is there any medication bottles laying around? Is there any alcoholic beverage bottles laying around? Any syringes, any drug paraphernalia, any unpleasant or odd odors? Did I see something suggesting a drug lab? If you do, you need to leave. Those can be very, very dangerous. Get the patient, get them out of there, and leave the area. People that have clandestine drug labs, they're very protective of them. They usually have very large dogs. They have lots of firearms. They may have booby traps in the front yard. So you need to be very, very careful if you suspect a drug lab. So get them out of the environment. That's job one. So these guys have got all their PPE and their masks and their tanks and everything on. Get them away from the source that has contaminated them. All right. Please make sure you're not contaminated by that same source that contaminated them. Get rid of the clothing that has been contaminated. Any articles like jewelry, whatever that has been contaminated, that needs to come off. And then we need to decontaminate. Okay. You need to get this guy more unclothed than what he is. And I know you may be, well, what about let's protect his modesty? Guys, that's great. I agree. But still, there may be whatever he was exposed to still clinging to the shorts, to the underwear, to the T-shirt. So that needs to come off. You may need to build some type of barrier around this patient to protect his modesty, but this is really not the way to decontaminate someone. Get your general impression, assess their LOC, do your ABC, see if there's any life threats. Open their airway, assess for breathing. If you need to put oxygen on them, put oxygen on them. If you need to bag them, then get your bag out, mask out, ventilate them. Make sure you assess the pulse, the skin color, the skin temperature. Again, if they need oxygen, please give them oxygen. Check their disability. That would be your GCS, your AVPU, expose and examine. Contact poison control. Okay, guys, Vital is your medical control, but poison control probably is your better source for calling in about a poison to try to get some type of idea about what it is and what the treatment is. Poison control has a huge database they can tap into, and anything you give them, they can probably give you an answer to. However, poison control is not medical control, and what I mean by that is let's say a kid eats some rat poison and you call poison control and say, hey, this kid ate a bar of rat poison. Is there anything you'd like for me to do? Yeah, that really doesn't bother us. Tell mom to give the kid 8 ounces of milk and follow that with 24 ounces of water. They don't necessarily need to be transported. You still need to contact medical control. If medical control says every poison, whether it be intentional or unintentional, needs to be transported to the hospital. Okay, so transport the patient. These are usually we need to go ahead and go right now if they are to the point that 911 has been called. Get your history taking, investigate the chief complaint. Like we talked earlier, you may have to do some detective work here to try to figure out what was taken, how it was taken, how long ago it was taken. Get your sample history on them. They may be unconscious, so you may have to get it from bystanders or family. Ask what was involved, how long have they been exposed to it, what was or when were they exposed to it, and how long were they exposed to it? Over what period did the patient take the substance? Has the patient or bystander done any intervention prior to you getting there? And how much does the patient weigh? You may be wanting to know, okay, why do we care how much the patient weighs? The charcoal that may or may not be given is based upon how much they weigh. Also, some of these medications, like we'll use Tylenol. A Tylenol overdose is also based on your weight as well. For example, let's just say that 25 milligrams per kilogram is a toxic dose of Tylenol. Okay, well, 25 milligrams per kilogram for a 100 kilo patient, then that's 2,500 milligrams of Tylenol that could make them toxic. All right, but if you've got a 50 kilo person, then it's only going to be half of that. So if that 50 kilo person took the same amount as the 100 kilo person, then it's probably going to be more dangerous and more toxic to the person that only weighs 50 kilos. Now, your secondary assessment, you may need to do a head to toe on these folks. Get your vital signs, your pulse, blood pressure, what their skin look like, respirations. Support their ABCs if need to. If you need to give them oxygen, then certainly do that. But if it's something that was inhaled or absorbed, please get them out of the environment as quickly as you can. If it's ingested, again, you don't carry charcoal anymore, so that's not even in your wheelhouse. And then contact medical control or the poison center and let them know what you've got. Again, medical control trumps the poison center as far as what you actually do for this patient. When you reassess, just reassess everything that you've done. Like we talked this week, patients are every 15, but unstable are every 5. But again, in a situation like this, they can deteriorate pretty quickly. So there's certainly nothing wrong with assessing a patient every 5 minutes, even though they may be stable. Communicate to the hospital what you've got. Try to let them know what's coming in, like what they've taken, all like that. You guys will only have to call Bytel, and then Bytel actually calls the hospital for you. Okay, so some specific type poisonings. Alcohol abuse. A lot of people don't think alcohol is a big deal. If you use it in moderation, it's probably not a big deal. But sometimes people, what moderation is to you may be a different definition of what moderation is to me. So don't ever go out on someone who has imbibed in alcohol and use a phrase or even think a phrase of he's just drunk. Please don't ever think that. That will get you in trouble. So make sure that you realize that the more intoxicated you get, probably the more stupid decisions that you're making, and the more likely you are to not walk properly, drive properly. So now you've got trauma into the mix. You think that you're 10 feet tall and bulletproof when you got a little alcohol on board. So you want to start picking fights with people. Trauma is going to probably result from that as well, probably more to you than it will be to them. So you have to make sure you keep all kinds of medical and trauma issues in mind when you're dealing with somebody who's under the influence of alcohol. So you can probably smell alcohol on their breath or even on their person if something has been spilled or whatever. They're probably not going to have the most steady gait as they walk. They're probably going to have some slurred speech. They may have some incoherent words. There's all kinds of different types of people when they're on alcohol. Some get violent, some get sloppy, some get sleepy. So you never know what kind of person on alcohol that you're going to be dealing with until you get there. Poor coordination. They tend to not react as quickly as they did when they were sober. They may be confused. They may be hallucinating. They may even have blacked out. Whether they're blacked out when you get there or whether they had a period of a blackout prior to you getting there. Now, with alcohol withdrawal, some people can go through programs and they don't necessarily go through the withdrawal issues that they may have if they just decide to do it on their own. So let's say you got an alcoholic and he decides to quit cold turkey. What that means is I'm quitting, I'm never taking another drink again. They can go into withdrawals and they get what are called delirium tremens or the DTs. They certainly can look like that they are having a seizure, which they can have seizures from this, sweating, trembling, they're hallucinating. People can actually die from the DTs. Again, they're trying to do themselves a favor by getting off the alcohol, but it actually can be fatal with some people. Look for respiratory compromise. And if you're so drunk that you can't even stand up, you may certainly vomit. And when you vomit and you're unconscious, then you have a huge airway issue that you're going to have to deal with. They should not be, if they're really under the influence, I guess you have to look at what is under the influence. If I drank one beer right now, I guess you could say that I was under the influence, but it's not that I can't make an informed decision at that point. Now, if I'm to the point that I don't know what day it is, where I am, who the president is, then certainly those folks need to be transported to the hospital, even though they choose not to be. Okay, well, we can have some substance overdoses. Some of these are illegal, some of them are not. Okay, I mean, there are good uses for uppers. Like if you're on Adderall or you're on Ritalin for your ADD, that's actually a type of amphetamine. That's prescribed to you. You take it the way you're supposed to, then great. But there also are uppers like methamphetamines that are made in clandestine labs. Downers, the same thing. You may be on some downers prescription-wise, but then if you're on Quaaludes that are made down the street in a clandestine lab, then again, that's not the way to go. There's a lot of good narcotics that are considered prescription drugs. But again, if you decide to take more than you should, then you can certainly have effects from that. Hallucinogens, volatile substances, so there's all kinds of different types of substances that people can take to overdose. So downers, things like Rohypnol or Roofies, this was huge back in the 90s. This was what was called one of the date rape drugs along with GHB. I haven't been to a club in years, so I don't know if this is still an issue, but back when I ruled the dance floors of the country western bars of Dallas-Fort Worth, there was a lot of GHB, a lot of Roofies that were given to female patrons of those bars. Barbiturates, and then the uppers, these are things like if you drink coffee every morning, then there's caffeine in it, then that's an upper. Cocaine, amphetamines. Some people are to the point in their life that they take a stimulant in the morning to get through their day, and then when they get home and go to bed at night, then they take downers to help them sleep at night. Okay, so with narcotics, Let me just explain to you what the word narcotic means, because you hear it used very in general terms where it really shouldn't be used. The word narcotic means sleep inducer. So when you hear on the TV that the police made a huge narcotic bust and it was 100 kilos of cocaine, that was not a narcotic. Cocaine is an upper. It's not a narcotic. Cocaine is certainly not a sleep inducer. Okay. So heroin is obviously illicit, illegal. There is no accepted use in the United States for heroin. Back in the early 1900s, heroin was actually in cough syrup, and I believe over in the United Kingdom it still is in their cough syrup. But again, it has no medicinal use over here in the States anymore at all. Codeine. If you get a prescription for Tylenol number 3, then it's got codeine in it. There also is codeine in some cough suppressants. Oxycodone or OxyContin at one point was the most abused prescription drug that was on the market. Anytime someone broke into a pharmacy to rob them or to burglarize that pharmacy, they usually were after oxycodone or OxyContin. Several years ago, this was so abused because back in the day it was crushable, and people would, take this, they'd crush it, they put it in their shirt pocket, and then they'd stick a straw in their shirt pocket and snort the oxycodone, without anybody knowing. When the FDA came out and told the manufacturers of oxycodone to no longer make it crushable, their sales dropped 87%. So we don't see this OxyContin abused quite like we used to. It's my understanding now that the most abused the most abused prescription drug on the market is Adderall, which is used for ADD and ADHD. So with narcotics, you can have what's called the opiate triad. They are probably going to at least have a decreased LOC, if not comatose. They get pinpoint pupils, and then they have respiratory depression. And when we talk respiratory depression, we're talking, we're well less than 10 breaths per minute. All right, hallucinogens, these can be things like PCP. These can be things like LSD. I'm sure that you probably see ecstasy a lot more than you see the PCP and the LSD. Ecstasy is also known as X. It also can be known as MDMA. Ecstasy is really actually a form of amphetamine, but it does cause hallucinations. Magic mushrooms, the psilocybin mushrooms, are the ones if you want to have a psychedelic vision, then the psilocybins are going to be the ones that you're going to want to get. There can be volatile substances like glue, cleaning fluids, model cement. Amyl nitrate is something that it's my understanding that some weightlifters will take right before they go in for a lift, and it gets more gets more oxygen to the muscles. Okay. So what do we do for a substance overdose? Be careful when you're restraining these people, especially the ones that are on PCP, the ones that are on cocaine, any type of stimulant like that. These guys can be extremely powerful. I saw a 16-year-old kid that had 3 cops and his dad on top of him, and the 16-year-old kid was winning. So you have to be very, very careful around these people that are on stimulants. They can get just really unhuman strength. Check for airway compromise, especially your narcotic overdoses. Level of consciousness, monitor their vital signs, treat for shock, and assess for any injuries. Something that's not on slides that let me just go over very quickly with you. There are all kinds of drugs that are in Dallas. K2 used to be, you could go and buy that at the GNCs, or not at the GNCs, but at the head shops. They made that illegal, but Billy Bob on the corner may be making it. You can go buy it from him. K2 is the one where the guy in, I believe it was Florida, that was on K2, and he found a homeless person under a bridge, and he ate the homeless person's face off. You also, cocaine is prevalent in Dallas. Obviously, heroin is prevalent in Dallas as well. Remember, with cocaine, cocaine can be the cocaine hydrochloride, which is water soluble, so it can be injected, it can be snorted, it can be rubbed on your gums. Whereas the crack cocaine is not water soluble; it has to be heated and turned into a vapor to be able to smoke. All right, with the heroin, you may have just your plain old, 10 to 15% pure heroin that they're injecting, but they also may have what's called cheese. Cheese heroin is black tar heroin that they mix with Tylenol PM, and the PM in Tylenol means Benadryl. Or if they have Xanax, they'll mix it with Xanax. You kind of have a 1-2 punch with the cheese heroin. It's actually pretty cheap, and that's what makes it attractive to a lot of people. But the cheese heroin, what's going to kill you acutely is going to be not only the respiratory depression from the heroin, but also the sedation effects that you get from the Benadryl or the Xanax. But what would kill you long term is the amount of Tylenol that you're taking into your body, and you probably are going to go into liver failure. Okay, so this is going to conclude toxicological emergencies. Please make sure you know the different routes that substance can enter into your body. Make sure you know how to treat, which, we talked about treatment for all of these. Really wasn't a whole lot of treatment for it on an EMT level. When you get to paramedic school, there are some treatments for some of these, but you're really kind of limited other than get them out of the environment. If they need to be decon them and get them to the hospital. So very little treatment that we talked about in this chapter. It's more of a recognition of what they have ingested and looking at the signs and symptoms and see if you can, it may be blatant. Again, the guy that we saw at the very beginning, he's got a syringe sticking out of his arm that says heroin on it. That's pretty plain and simple. However, some people can, do what's called speedballing. He may also have cocaine mixed in with that heroin as well. And so you could get some really wild looking signs and symptoms if someone is mixing drugs like that. So this concludes these 2 chapters. Again, hopefully you got all the information that you needed, and I'll talk to you soon. Have a good rest of your day.